So patients live longer, they need more treatments, and we have more cancer diagnosis. We're really being outpaced in our ability to offer treatment to everyone in our physical spaces. So we either think creatively and we design a system where we can get care to more patients and also make the care more patient-friendly, or we build more chemotherapy units.
Cancer touches nearly every life, and the journey through diagnosis, treatment, and recovery can be overwhelming and challenging. But what if the future of cancer care was more connected, personalized, and accessible? Today, we're talking to two experts about innovations in cancer care at every step. That's on this episode of Tomorrow's Cure, a podcast from Mayo Clinic that brings the future of medicine to the present. I'm Kathy Wurzer. Thanks for being with us. Today, we are speaking with two doctors who want to make care better for those who have cancer. So pleased that Dr. Roxana Dronca is with us. She's a hematologist and oncologist at Mayo Clinic in Florida. She's the director of Mayo Clinic's Comprehensive Cancer Center. She's also running two clinical trials on the effectiveness of at-home care for patients undergoing chemotherapy. Dr. Dronca, thanks for being with us.
Thank you very much for having me.
Dr. Arif Kamal is also here. He's the Chief Patient Officer at the American Cancer Society. He's an expert in oncology and palliative care medicine. Palliative care improves the quality of life and reduces suffering for people with illnesses that are serious, complex, or terminal. Dr. Kamal, thanks for taking the time.
Yeah, thanks for having me.
I would like to begin, Dr. Kamal, maybe setting the stage for our conversation if I could. What does the spectrum of cancer care look like nowadays?
Yeah, I've heard a lot of different terms used by patients that I've seen, unnerving, complex. And for many people, it can be dehumanizing, right? The concept that every 15 seconds, a person's going to hear the words, "you have cancer," means that their entire future will be questioned. Their relationships will be tested. Their financial security will be stressed. And for many of them, there's a long road of uncertainty and hopefully a lot of compassion along the way as well. And what that means is that it's our responsibility, I think, as that happens, to bring as much normalcy as we can to an experience that is going to be unanticipated and oftentimes full of ups and downs. And so, as we think about the cancer care itself, we spent a lot of the last 20 years thinking about what people should get, how often they should get it, what doses they should get, and really leaning into R&D. So making sure that we have options and choices for what people could use to get better. And now we're starting to really think about where they could get that care, what that looks like, so that their surroundings are more familiar, so the experiences of what they're going through feel a lot closer to normal. Because as we know, the one thing that many of my patients certainly reflect on is that their sense of agency, their sense of control is oftentimes taken away. And so giving people back a sense of control is oftentimes, I think, now a lot of focus of what we're doing in cancer care.
Dr. Dronca, does that ring true to you?
Oh, so very true. I hear from my patients all the time. I've also lived it as a caregiver for a loved one with cancer. It really takes over your life, not only the diagnosis and the treatments, but you cannot even focus because, to what Dr. Kamal mentioned, every 15 minutes there is something, there is a test, there is a procedure, there is a travel, often not in the same building or potentially not in the same campus, not by the same doctor. So it's a whirlwind that patients have to navigate, in addition to navigating the diagnosis of cancer, what they need to do to get better. The logistics take over a lot of times, a big part of their care. So I think what we want to do collectively, and what the movement is, to really redefine the way we care for patients with cancer, to have a care that is more patient-centered, that brings the care to the patient, not only expecting the patient come to us every single time.
I'm glad you mentioned logistics, because I have dealt with this in my own life too with parents who have cancer. I did not know that patients can spend up to 10% of their time traveling to cancer treatments. And of course, we all know that chemotherapy can be like a day-long experience. And I'm going to assume that does not aid in healing. Am I right, Dr. Dronca?
It doesn't. Actually, a fraction is spent with the nurses and the physicians and the people providing care. a lot of the time is spent traveling to and from, checking in and out, waiting in waiting rooms or, in the lobby for a test result to come back, to see a provider, to check in for a chemotherapy when the chair becomes available. So a lot of it is the waiting, not necessarily the care that we provide. And patients have their own life. Some people work, some people are single parents, and these treatments are not once every 3 months, often is one every other week. So people have to actually think about caring for the other people in their life. So it actually affects the entire family, not only the patient who has the diagnosis and who needs the treatment.
I understand that you've been touched by cancer. You have lived experience. Dr. Kamal, I believe your mother had
That's
cancer. Is
right.
that correct?
That's right. Yeah.
And what was that experience like for you as a caregiver?
I was in high school, so it was a very formative experience for me. I grew up in a small town in the middle of the Midwest, and so the closest cancer center was nearly 2 hours away. And so, all the logistical barriers, as Dr. Dronca is mentioning, came into play, and certainly there felt this sense of like magicalness of going somewhere. But now as an oncologist, I look back on that experience and I realize that like I think we set up the system to work that way. There wasn't really anything magical about leaving our home so much. Our community, our friends, our social support network was all there. And, there was this burden of having to go somewhere else. I think that for caregivers, oftentimes, we're the sort of the silent ally that exists in a room. And oftentimes I find that caregivers don't get to be seen and heard in terms of what they're doing, because it's seen that the medical profession is focused on the patient and the patient only, which when we really think about it, the other 90% of the time they're not with us in our building. Those caregivers are our eyes and ears. I mean, they are the ones who are going to the pharmacy. They're the ones calling us at 2 a.m. to check in on something. And we know that in the cancer context, and I imagine in other health contexts as well, that for patients who don't have a primary caregiver, meaning one person sort of designated to spend more than 50% of that time with the person, that outcomes are poorer. We know that adherence to medication regimens go down. We know that adherence to appointments and scheduled tests also go down. So there's such an enormous responsibility, burden, oftentimes a sense of satisfaction, but also significant work placed on the shoulders of people who are caregivers. And I think it's also important that us as healthcare professionals really see and pay attention to them, and also just paying attention to the emotional and physical needs, because we know that caregivers oftentimes forego their own health treatments or their own sort of health conditions during that time, which means not only is the patient hopefully getting better, but at the same time, the caregiver could be getting worse. And that's nothing any of us actually wants to have happen.
Thanks for your kind thoughts on caregiving, by the way. I appreciate hearing that. Dr. Dronca, I know you've had a very difficult experience with cancer. You have a daughter.
Yes, my oldest daughter was diagnosed with an incurable brain tumor in January of 2020, a few months before the pandemic hit. I knew right away that this was going to be a tremendous fight and potentially not a winning one, but I went in it 100%. I forgot everything I knew about oncology, and I was sure that my daughter will survive. We traveled to Rochester. She got radiation treatment there during the pandemic, and it was a very scary time. We did not know, even as a Mayo physician, I did not know if the chemotherapy unit was going to be available tomorrow, if patients are going to be able to be seen in the clinic, if my daughter would have access to what I thought was the life saving medicine, to the life saving radiation treatment. I lived in fear of this virus that nobody knew about, but I also lived in fear of not being able to treat my daughter and for her to receive care for her cancer. And I imagine that the cancer patients and families navigated the same uncertainty that I did during the pandemic. As she got progressively sicker and weaker, it was very difficult to take her to the hospital. And sometimes we would travel 20, 30, 40 miles across downtown Jacksonville for her to have a blood test or to have an infusion, an Avastin infusion that basically is no reactions, nothing. And I remember thinking, if I only had this in my home as an oncologist, I would administer it right away. I started looking for remote labs to see if there is anybody who would offer something like this in Jacksonville so she can be spared one trip. She would have seizures in the car. It would be so difficult. It would take us 40 minutes just to position her so she can make the drive. So I remember thinking if I had it, I would do anything to have even a fraction of our care done in the home so we don't have to drive every single time. So after she passed, I promised myself and I promised her that I will do everything in my power, that other children, other patients with cancer, other families will not go through what we went through, or at least that we would make it easier on them. That's when I started thinking about how can I use my knowledge as an oncologist and my experience as a caregiver, put them together, and see if I can help other cancer patients.
Thank you for sharing your story. That is so difficult, and I'm so sorry that your daughter is not with us. Those experiences, as difficult as they were, they obviously informed then your work with Cancer Care Beyond Walls. Was that program in the mix prior to her diagnosis, or did this come after?
No, it wasn't, but Mayo Clinic in Florida started the advanced care at home, the hospital at home, during the pandemic. After I came back to work, I realized that we could use a lot of the learnings from advanced care at home and the infrastructure that was created for hospital at home to potentially apply to patients with cancer. The difficult part is that chemotherapy is hazardous medication, that there are no rules and regulations around giving treatment in the home. And everybody I asked, said this is probably not possible, it's not the same thing. We're dealing with a lot more serious treatments. But again, as an oncologist, I kind of knew how much we can do safely and with the same quality of care. I remember asking for an interview with our Mayo Clinic CEO, Dr. Gianrico Ferrugia, where I explained the idea and the vision to potentially think about doing this for cancer patients. I think it took him about 2 days before he convened the Mayo senior leadership and asked me to present the idea in more detail and gave us the green light to go with the pilot and see if this is something that patients would embrace and would need and if it would provide benefit. And that's how Cancer Care Beyond Walls was born.
My goodness. Dr. Kamal, before I dive into the program itself, what are your thoughts when you hear this?
Well, first of all, I really appreciate my colleague and friend Dr. Dronca sharing her story. I reflect as a palliative care physician that it's hard when you lose someone. I really admire Dr. Dronca because she took what was incredible loss and has channeled that energy into making the world a better place. I think there's a lot to learn here about compassionate care. And, there's many ways to sort of define compassion. I think about compassion as empathy in action. And empathy means hearing people's stories, like Dr. Dronka sharing hers, and there are many, many others too, where people look at that experience and say, there's got to be a better way. There's got to be a different way. And so that means there's data and there's stories, and that's both going to contribute to our empathy. And then we have to take action. And as I started to say, cancer care is magical, yes, because we can do some things now that we couldn't do 5, 10 years ago. But also, there's a lot of what's happening in cancer care that's increasingly looking like other diseases that hopefully for many people are longer stories with less intensive regimens of treatment, or if there is high intensity, it's for limited periods of time. And there's a focus on what things will look like on the other side. And I think for many people, that means pulling through a sense of normalcy as much as we can through it. And I think part of compassion is recognizing that as oncologists, we are privileged to take care of people in our presence, in our cancer centers, in our clinics. That is, as nice as people are to us, being in our clinic is not where they want to be. They'd rather be with their dog, right? They'd rather be watching the hummingbirds out their window. And the thing is, there's not a false choice, as Dr. Dronka is showing in her work, is there isn't a false choice between one or the other. And I think cancer care, part of the scariness of it is how unknown it is, how unfamiliar it is in its approach. But what if we could soften it by making components of it actually feel as normal as we can get? Now, there are important issues to consider related to safety and other things too that we have to think through. So this is not something we jump into lightly, and why folks like Dr. Dronka are doing really important research to really understand the question of who and when and how. And we have to keep thinking through that. But I think fundamentally, we're going to look back 5 years from now and wonder, why weren't we doing more of this? Because it always felt like the right thing to do.
When patients start a treatment regimen that would be suitable to be administered in the home, they receive the first 1 to 2 cycles in the infusion unit to ensure that they don't have any unpredictable reactions and that they tolerate the treatment well. After that, for patients who need some sort of remote patient monitoring capabilities, a technology pack is installed in their home that involves vital signs, Bluetooth enabled, a blood pressure cuff, a pulse oximeter, thermometer, a scale, in case patients need to take their vital signs at home and then they get uploaded in their medical records. Patients also have a tablet, which is extremely user friendly, that connects them with the command center, with their care team on the other end, whether it's through their appointments or with any questions that patients may have and they need to reach the command center. That tablet also has their entire schedule, the patient schedule, so it's very predictable. Patients know what time the courier will be there to drop the treatment, what time the home health nurse will come in. Before treatment, patients get laboratory workup done in the home, and then they get a virtual visit with one of our physician assistants in the command center or with our medical oncologist to ensure that they are cleared for treatment. Our command center oversees the administration of treatment in real time. Our command center is staffed by senior chemotherapy trained nurses who actually are online, stay online with the home health nurse during the treatment administration to ensure that there is no adverse reaction or any questions from the home health nurses that they would need assistance in resolving. We also have a medication kit in the patient's home in case they have a reaction.
Are the loved ones in the home, the main caregivers, are they the point person for this?
No, there is somebody else to help. And actually, the home health nursing agencies that we work with, our chemotherapy nurses in our program provides education, both hands-on as well as didactic education to the home health nursing staff that we work with in such a way that their skills are now elevated to being able to administer cancer treatments in the home under the direct supervision of our command center, and also meet the dual person verification criteria. So, two nurses on two different ends check the patient identity, the dose, the time, the drug, labeling, etc. What we are learning is that having the patients connected with the care team, the virtual care team, the command center that they know they can access at any time actually prompts them to discuss some symptoms early. The real time monitoring of their symptoms, the ability for our nurses and physician assistants in the care team to escalate the symptoms and provide guidance on treatment of symptoms such as nausea, dehydration, pain, or fever early. Dispatch supportive care in the home before the complications get worse, before the patients have to come to the emergency department or be admitted, actually keeps a lot more patients out of the emergency rooms, which actually lowers the cost of care for everybody, for the payers, for society, and for the patients and their loved ones. So I would absolutely agree that we can look at the cost as a total, and we see benefits both for the patients as well as for our healthcare system in general. I would also fully agree that once we know how to do this with standard of care drugs, then the next logical step is to do this in the context of clinical trials, some experimental medications and or diagnostic tests that now we know how to dispatch and to decentralize to reach more patients than those who live 70 miles from a big academic center.
Dr. Kamal, what's driving this, do you think?
Well, there's multiple positive pressures in various different ways. We do know that cost of cancer care can actually be lower in some instances where this is done in this way. And, now you've got the amazing ability for many people to have their diabetes under control or weight loss through a self injected drug. You've got many other examples, even in cancer care, where you have patient control over that component of care. For example, we've had for years now colon cancer screening at home done through stool based tests that patients can do on their own. Just had FDA approval for self sampling by women for HPV. Okay. So we've known already that putting it in the hands, physically, literally in the hands of patients and caregivers in cancer early detection works, is convenient, and actually increases uptake of some of these screening tests. Now, what we're doing is just moving that dial along the continuum to say, well, now let's focus on treatment. When in fact, actually, we've been doing survivorship and end of life care at home too. So this was kind of that area where we hadn't done as much, but we've learned a lot in cancer early detection and survivorship and end of life care that we can now apply to the treatment space.
It sounds like this is also a matter of health equity. Am I right about that?
And we're talking about equipment, we're talking about access. Clearly, there's parts of the United States that home health is a little harder to find, where Bluetooth and Wi Fi connections can be a little spotty. So I think health equity needs to be intentionally preserved in these approaches. But if so, can it increase? Absolutely, it can, because this now also means that distance or geography does not have to be a rate limiting step to accessing high quality care. And importantly, for the 7% of adults with cancer who participate in clinical trials, which is extraordinarily low, to get that number up means we have to increase access and decentralized care like this. Imagine now clinical trials coming to a person's home, where that number could go. And I'll remind everybody that, when people ask me, gosh, if you look at the pediatric cancer space, what remarkable progress has been made in the last 20 years, where, for example, pediatric leukemia now survival rates between 65 and 75%. It was exactly the opposite about 20 years ago. And so when you ask the question, how did the cure rate get so high in such a short period of time? That is in no small part to increasing number of children being enrolled in clinical trials. In fact, it is the standard of care in pediatrics. It's not yet become the standard of care in adults. But if we get that number north of 7%, gosh, it's certainly optimistic to think that our cure rates in adults will go up as well.
I mentioned in the introduction that you are working on 2 clinical trials that are comparing the administration of chemotherapy and immunotherapy in the home versus clinical settings. Do you have any early information to share?
We have 2 clinical trials indeed that are gathering objective data to learn if this is better for patients, both in terms of their experience with care as well as clinical outcomes. So, one trial is looking at administration of chemotherapy and biologics in the patient's homes for a part of their care versus the infusion unit for the remainder of the number of cycles, and is looking at endpoints such as patient preference with the site of care, overall patient experience with care, as well as clinical outcomes in terms of treatment, adherence and compliance, ER visits, hospitalizations, quality of life. We're looking at safety, and we're also looking at cost. The first 50 patients, like I mentioned, were analyzed. And while I cannot say any early results, I can say that it was really beyond even our expectations. The other trial is looking at administration of subcutaneous nivolumab, which is an immunotherapy in the patient's homes versus the infusion unit. And making a parenthesis to what Dr. Kamal discussed about patients taking control over their treatment, I really do think that we are not very far from some of these cancer drugs actually being self administered by patients in their homes and not necessarily needing a home health nurse for every treatment. And we're talking about the treatments that really can be done in this way. For instance, subcutaneous medications that are short injections. But the most important thing in oncology is to have the oversight, the care team oversight, to ensure that before administration of the drug, the blood tests that need to be checked were checked and they are normal or they are satisfactory for treatment, that the patients are cleared by their care team to receive the treatment, and then potentially afterwards having the patients, I think, self-inject some of these medications.
What do you think your colleagues might think of this idea? Do you think there might be some skepticism perhaps when you hear about patients self-administering their own chemotherapy at some point?
There will be, and it'll come from a good place, which is really around patient safety and making sure people get what is going to be helpful to them. I think there's a important push and pull there that exists that's very healthy to talk about what's the maximal tolerated dose. I mean, we talk about all the time is which is the most amount of therapy we can get into a person while hurting the cancer and benefiting the person. There's always been this sense that the best way to do that would have to be under our eyes in our building, under our purview, and most of us trained being on call in the building to come in and help someone with an anticipated outcome. But I also think there's an evolution here in cancer care that's just happening that all of us are a part of, which is that if you ask the average person, what does it look like to be a cancer patient, right? Someone's walking down the street and you ask them that question, they may give you this visual of a person who's bedbound, vomiting, losing their hair, right? Not able to do the things they want to do. And the reality is that for many patients, if not most, particularly in many of the diseases I treat, many of them are not getting cytotoxic chemotherapy as first line. Or if they are, they're getting that as the backbone to many other precision based medicines on top of that. And so fundamentally, our ability to be more intelligent in targeting a tumor and less targeting of normal cells gives us the ability, this awesome ability, to do this in different ways. And I think if we position it as innovation with safety, as the natural step forward to making cancer care more compassionate and kind, while also preserving and respecting patient choice, then it gives us more opportunity to be compassionate in how we treat people.
Wondering in this day and age of artificial intelligence, the command center sounds like an interesting concept, right? Would there be a point somewhere down the line where AI would also add to the effectiveness of a command center?
I'm absolutely convinced that there will be, and actually, our Mayo Clinic platform colleagues are already working on this because a lot of the feedback that we get from patients and or questions can be triaged in such a way that they go to the nurse practitioner, they get escalated to the oncologist in such a way that you maximize the time to get back to the patient and actually maximize how the different components or the different staff members that work on the different aspects of care.
Do you see hospital systems, Dr. Dronca, supporting this concept or maybe being, again, skeptical?
I see both, but I see that there is no choice. Every time I speak about cancer care beyond walls, and I remember speaking at a meeting where there were a number of chief medical officers and CEOs at that meeting, and a number of them came to me and said, we need to think about something like this because we have no more room in our chemotherapy units. And the chemotherapy units are packed. We're having a difficult time initiating new treatments for patients and also keeping up with the number of treatments. Why? One, because we have an increase in the number of cancer diagnoses, and that's not good. But two, is because patients now live longer. With all the advances that Dr. Kamal described, everything that has happened in the last couple of decades in oncology, patients who are diagnosed with cancer today, half of them live 10 years or more, but often they need to undergo repeated or successive lines of treatment. So patients live longer, they need more treatments, and we have more cancer diagnosis. We're really being outpaced in our ability to offer treatment to everyone in our physical spaces. So we either think creatively and we design a system where we can get care to more patients and also make the care more patient friendly, or we build more chemotherapy units.
Both of you are spurred forward by obviously something personal in your backgrounds, given, as I say, your lived experience with cancer. Are you finding this work feeding your souls in a sense?
I wake up in the morning and I think about, do I have a meeting? Do I have something about cancer care beyond walls? What else can we do today? What else can the team do? We're now pushing the boundaries to see how we can do care in rural areas, how we can do, other ways of reaching patients. So I wake up with this in mind pretty much every day.
Well, I always remain inspired by Dr. Dronca. The experience that we went through as a family can be much different and better for the future families who are going to hear the words, you have cancer. In the world of cancer, people think about therapies and surgeries and scalpels, and there's a very impersonal nature to cancer care that people assume just has to be the way, right? Because people assume that if you have to be aggressive, right, which is what people want to be when they're tackling cancer, that aggressiveness equals being impersonal. And I think what we're both demonstrating here is that, we're driven in a way where we don't think there's a trade-off between being aggressive in the sense that you're driving towards the best possible outcomes and being compassionate at the same time. And at Mayo, a current state of cancer care that is beyond what anyone could have imagined even 10 years ago, and so eloquently reflects how much progress we've made as an oncology ecosystem. It really is an amazing thing to think about.
It's fascinating. Thank you, doctors. Really, it's been a pleasure having you on the program. Best of luck.
Thank you very much for having us.
Yeah, thank you.
Tomorrow's Cure is a co-production of Mayo Clinic and PRX. Our producers are Deborah Balthazar and David Newtown. The show is edited by Genevieve Sponsler. Our sound engineer is Tommy Bazarian. Our theme was composed and produced by Terrence Bernardo. Tony Carlson is our production manager, and our executive producer is Jocelyn Gonzalez. The Mayo Clinic production team includes Hui Hong Ang, Margaret Shepard, Samantha Clarkson, Kara Mangold, Felipe Sosa, Kim Ona, and Bryn Sankey. Special thanks to Preston Spire for audiovisual production support. Be sure to follow Tomorrow's Cure wherever you get your podcasts. I'm your host, Kathy Wurzer. Thank you so much for listening.